Hey Mo,
Hey Ricky, how you doing?
I am great. It is a beautiful day. I know you're buried in snow. You got to show a picture of your house.
I'll show it at the end. Yep, I'll
Yeah,
have to show it.
yeah. No, we
But
just got 4 inches here, but that shuts our area down a little bit. But
yeah,
it's
we had
beautiful.
almost
It's
20 inches
time.
here, but no matter what, the doctor is still in. And we
The
got a
doctor is in.
show for everybody tonight. Tell them who we have tonight.
We have it's Black History Month, so we got to talk about history, and we got a
All
lot of
right.
history, and we got to talk about how a lot of history hasn't really changed. Hello,
Yeah.
right? Hello, regarding health. So I have we have great guests as usual, but we have my link sister, Dr. Andrea Reed,
Love it.
who's a brainiac, and you can't. She has like 4 titles, okay, at Harvard. I couldn't even fit them on the flyer because she has so many titles, and you'll see that today. But she is just a badass brainiac, changing the face of diversity at Harvard Medical School. So pretty
Beautiful.
cool. And then my friend Z, who I really just met a few months ago, and we're on this committee together that's talking about mental health and technology products, and she is just a force to be reckoned with, and she is taking the world on in Oakland, in the Alameda Health Center, and like dealing with their people and trying to make everybody have equity care. And we're just going to have a great discussion about history, kind of what happened, why we don't trust the world, why don't we trust doctors, why don't we trust research, and how we can fix it. So, and
Right.
how we are fixing and how it's impacting our patients now. So what I would love for Andrea to start kind of talking about the history. I talked to her like a couple months ago. She did this interview for me, and she gave me this whole history lesson on like stuff that happened and why people are fearful. So that would be great, and then we'll let she have it and talk about what's going on in the world today. But
Oh my
I'm
Love
so
it.
glad you guys are here. I love you. So happy.
Thank you. Well, thank you so much for having me. Obviously, it is Black History Month, and it's a great time to think about not just our history currently and where we want to go, but the history upon which a lot of the negatives are based, meaning that medical mistrust is based in a history that was very, very painful, and that continues to be manifested in the way that Black and Brown individuals are treated in this country. You and I talked previously about some of the history, so I'll just outline a little bit of it. There's a great book called Medical Apartheid that really does outline a lot more about the history of the interaction between Black Americans and the medical establishment. But a lot of people, when they think about medical mistrust and where it comes from, and especially in the Black community, is regarding the syphilis project that was based in Tuskegee. People call it the Tuskegee Project, but that makes it sound like it's specific to a school. It had nothing to do with the university. This was a government-sanctioned study that basically involved leaving individuals, 400 Black men with syphilis, untreated, though they thought they were being treated, leaving them untreated in order to see the effects of latent syphilis, just allowing it to have its natural history in that population. And not only was it not treating these men, but also actually prohibiting them from getting access to adequate treatment once penicillin was available. So it barred them from getting treatment elsewhere. And so the effects, of course, were not just on those 400 men, but on their families, on their children. They suffered greatly. And this was a government-sanctioned study that went on until the early 1970s. So this was over 30 years of medical malfeasance. But it's not the beginning. It has had a searing effect on the Black community. Whenever something new comes out, there's this like why they're trying to trick us, and this relates to, of course, concerns about the COVID vaccine. But the history of medical malpractice with regards to Black and Brown individuals starts, before slavery. There were, especially for Native Americans, not only were they shepherded onto poorly resourced reservations, but they also were forced sterilized. Their children were taken from them, put into boarding schools, and they tried to eradicate their language and provide no health care after giving them diseases that came over with the white man. during chattel slavery, all kinds of procedures were done on slaves and on sharecroppers afterwards that allowed doctors to perfect their techniques. One of the most egregious was that of J. Marion Sims, who is considered the father of gynecology, who practiced his procedures, his GYN procedures on slave women. There's a very famous picture of a Black woman on a table with a headscarf and kneeling on her knees. And this was one of his subjects. And so he did not use any anesthesia because people didn't believe that Black people had pain. Perfected his techniques even in front of others on Black women. And then once he had perfected them, took them to Europe to do them on white women with anesthesia. There was something called the Mississippi appendectomy, which was actually medical students practicing on Black women. When they go in, say, "Oh, you have belly pain, we need to take your appendix," and they would sterilize them, take their uterus. This is one thing that happened to people talk about. Fannie Lou Hamer was one of those individuals who was a victim of a Mississippi appendectomy, as they called it. There was forced sterilization of Black people, people that were mentally handicapped, Native Americans. This went on for generations. And so has a long-standing impact on the individual's ability to trust that the medical establishment is going to benefit them. I tell people medical mistrust was earned. And therefore, to get the trust of individuals, it's not like it's irrational. In fact, there were bad things done. There were individuals, there's studies even now. In 2016, there was a study that showed that medical students, over 50% of medical students thought that Black individuals had less pain endings, nerve endings in their skin, that their skin was thicker and had less nerve endings, and therefore that they had a higher pain threshold and needed less pain medication. So this, study after study has shown that there is disparities and inequities in treatment of pain, in how broken bones are handled, treatment for sickle cell pain, under treating that based on what they think are objective criteria. They're just replete. The literature is just replete with studies that show that that a sense of a worry about medical mistreatment has been well earned. And so it requires a very, very concerted effort to roll that back. But the history is egregious. And those are just a few examples.
I know, and then there's Henrietta Lacks, where basically
right,
kind of all the cancer research kind of came from her cells, right?
Oh, yeah.
Right. So Henrietta Lacks is another example. It's a little bit different, but equally important in that Henrietta Lacks was a poor woman who had a very aggressive form of cervical cancer, and she was admitted to Johns Hopkins Hospital, where they did provide free care for Blacks. It turns out that during her surgery, without her consent, a part of her cervical cells was taken. They have been trying to figure out a way to immortalize tumor cells for clinical studies forever, for research. And it turns out that her cells were able to replicate in a way that no other cancer cells had been able to. Of course, it didn't make a difference in terms of whether she lived or died. It wasn't that her treatment changed her outcome, but the fact was this woman's family had no idea that this part of her was taken and later used to create this immortalized cell line that has truly changed medicine forever. Its importance cannot be overstated. And the La was from her first initial of her first name and her last name. I worked with HeLa cells when I was in a residency fellowship. I did research with HeLa cells. I never knew the story until I read the Immortal Life of Henrietta Lacks.
It's true, yeah.
Of course, her family got nothing because of it.
Right.
There was and they live in abject poverty.
Yes.
And so they suffered tremendously. The person who immortalized these cells did not make money off of them, but the reality is there was no informed consent to take that from her. And at the time, there was no commitment to getting informed consent from utilizing body parts or tissues from Black and brown individuals. So it's just another example of how Black people were considered less than.
Mm.
Absolutely. So much to unpack there. I remember being a graduate student and doing research here in Philadelphia at Fox Chase Cancer Center, and we use HeLa cells all the time, and never really knew, you know, the history of that until I did the research, until I read the book, and it's just unbelievable. But I want to go back, and for the people who are watching who maybe are watching for the first time, or those who are beginning to get a growing, budding interest in diversity, equity, and inclusion work. You know, we like to sort of fast forward through history, and we like to say, okay, but that was the past, that was decades, that was centuries, that was, you know, and when you look at the timeline of Blacks in America, right? When you go back, so slavery, 1619 to 1865, 246 years in this country as slaves. 246 years. And then another 100 years, 1865 to 1965 of Jim Crow. 20 years of civil rights, 1955 to 75 or so. And we're looking at only about 45 post-civil rights years from the civil rights movement. Only 45
2 generations
years out from that. 2 generations out from the civil rights movement. And so it's very convenient to try to say, well, that was then, and these were, you know, different times, et cetera. But the history really does dictate why people feel the way they feel today. And like you said, you know, whenever I have the opportunity to speak about these things, I always say, you know, the medical community has not earned the trust. I don't say the distrust inherent among Black people, or, you know, Black folks' distrust of the medical establishment has not earned the trust.
Exactly.
And the same goes for cancer care. You know, Ricky, you can attest to it. Jeanette, I want to hear your story. Z, tell us your story.
I'm sitting here just trying to take it all in because I'm looking at this as I've seen my patients experience it and how I've witnessed it, not as a navigator, but as a Black woman. And certain things, you know, I frame a little differently depending on who and what the situation is. There are times when the medical community hasn't earned our trust, but there are times when they haven't invested in it, earning our trust. And I feel like I can't talk earnings without talking investment. Mm-hmm. You know, they literally go together. That's our system. You know, that's capitalism. And a lot of it is a weird type of capitalism that I feel like I'm watching and I'm looking at, you know, because we're still devalued to a very large extent. Because if I'm equal to you, then the investment should be the same.
Ooh, break that down.
You that there's going to be a return on that investment. So if there is no investment, what's the question? Okay, so then I have to take it there. And then I'm saying, okay, so who decides what gets invested into? And are we at that table? You know, so it kind of has evolved for me. When I first began this work, I went in, I had no medical experience at all. I've worked with communities that were disempowered, but I never worked from the medical perspective. So it's like I'm working with the flip side of the coin, but the intersectionality, I can't divorce from it. When you have a people where they can't get housing, no fair housing, no fair criminal justice system, no fair employment system. You have all these systems where there are different injustices. Why would I believe you care about my life in any regard? And you know, that's what people fail to realize. This is how my patients see it. They're not looking at it. It's not compartmentalized to the extent that people think like, oh, it's just about my health. No, this is about my life. And I'm in a system that has not shown me any respect or real regard along the continuum or with any consistency that will have me trust that of all the areas that you haven't invested in, now you want to invest in my life. And when they have a share cost that exceeds 70% of what they may get with their disability, you can't even respect trying to help me with a disability, but now you want to help me save my life.
Wow.
So, you know, I feel like when I first started, I tried to talk the language of cancer. You know, I tried to use all the right acronyms, SDOH, blah, blah, blah. And I felt like it got to a point where I felt ineffective because I wasn't telling truth. I was replicating, you know, and using different terminologies that did not speak to or for my patient.
Hmm.
Now that I speak the way I see it, I speak the way they've experienced it, I feel like I'm in a position to hopefully broaden the conversation where now we're not talking about disease, we're talking about life in every area. And that we seek to ensure and instill that there's justice throughout that life. You want to talk about whole person care? Okay, that's whole person care. We're going to talk about whole person care because now we're going to get intersectional. We're going to talk about criminal justice. We're going to talk about housing. We're going to talk about all these things because at some point that may impact my patient. You know, that could be one of their barriers to care because they're coming out of the carceral system and they didn't get a breast cancer screen. Okay, so now I got to look at criminal justice and breast cancer screenings. They may be a patient that is on the precipice of homelessness, you know, that can't go into chemotherapy because they're housing insecure. Okay, so now I got to look at housing. So, you know, it's just following the way things evolve and not being afraid to challenge framework. Because if there's no framework equity, then that to me is not a framework, that's a trap. And I have to address it and say, okay, let's just make sure that where's the equity in this? Let's broaden this conversation and let's really give some depth into whole person care. Let's make it relevant to the person that's experiencing all these things. So that's just, you know, kind of where I'm at from where I started.
I love that you broke it down this way, right? Because you've got, there is a vernacular, there is a vocabulary that we use in this space. You know, I hear you talking about structural violence and structural racism and structural competency and all these things, all these systems and social determinants of health and all the words that we like to throw around, especially, you know, when we do these lectures. I gave a lecture last week at the medical school and we talked about these things and, you know, is that vocabulary important? But then there's the dichotomy where, you know what, it may be important to the student, to the learner, to the physician to begin to look at and understand these systems. But to the patient, this is life. And life is really, really real, right?
Exactly.
And so making that distinction and being able to help patients understand that, you know, and help clinicians understand, because, you know, when we're on this side of the table, you're thinking about the diagnosis, you're going through your algorithms, you're thinking, okay, NCCN and the guidelines and this and that. Well, guess what? You can't deliver chemo to the street, right? You have no home, you can't deliver services, right? You've got great, you know, ancillary support services for cancer patients. I've got organic produce. Well, where's it going to go?
Right.
Who's going to cook it? How are they going to eat it? You know, moreover, do they have heat? Do they have light? Do they have, you know, mental health? Do they have support? Do they have health literacy? They even understand the diagnosis. And so it's a lot to unpack that. I think we can say that the racism has effectively really burned a lot of bridges for Black folks in terms of health equity. And it's not just through the delivery of care.
That's very true. It's all about intersectionality. And again, this is language that I had to learn and I'm still learning as it pertains to the medical field. And it was a really challenging because here I am, I'm a Black woman. And I'm looking at this and I felt so powerless and so helpless. And then a lot of times so angry because I'm like, they come in, my patients, and even me, you know, being a marginalized woman, trying to move another marginalized woman, that's a whole nother conversation. But you feel helpless because it's like, you want to encourage your patient and you want to support them as best you can, but then you're looking at all these different systems that are so overwhelming that I don't want to lie to my patients, you know. So then I just started fighting for my patients beyond the cancer, you know, because I tell people I don't navigate cancer, I navigate life. This is just another part of their life. And once it got to the point where I stopped trying to just navigate cancer, then I felt like that's when I started learning more and finding more resiliency and being unafraid to challenge and to just declare. Because sometimes you just got to declare. You got to look, I'm not using the planks that you're using because they don't work. I can't walk on those, a little shaky. But here, I'm here to offer you these. Let's see if we can make these work. So a lot of it is finding our own power, you know, and for Black folks, at least the ones, you know, that I revere and the ones in my life, it's about being able to stand in your truth, you know, and it's about trusting for me and God, and knowing that there's a purpose for it all. If I don't tell it the way it exists, we will not be positioned to address and resolve it as it exists. And we'll keep focusing on what we understand.
Ooh, you preaching.
And what we understand is not synonymous with our existence. Not always. Where it fits, where it doesn't, it doesn't. And so, I believe once we start seeing people as people, we'll start approaching solutions as people. Not as Black, not as poor, not as this, not as that. I think coronavirus will help us because there's so many people now that's suffering all the social determinants that, poorer and Blacker and browner people have been suffering. But now that they understand you can be susceptible and this can happen to you, perhaps now this is an opportunity in which we can really build a system that helps people. So, that's just kind of where I'm at with it.
Now, Ricky, let me ask you from the patient perspective, right? Because you've been there before, wrapping your mind around your diagnosis, around what is triple negative, around, wait a minute, you mean I need chemo, around what is a stage and what is a grade and all these things, plus all the life stuff, right? Plus the effects potentially, that you perceived of bias in the healthcare system. How does somebody who's watching, who's going through this, because we had a lot of breasties watching, right?
Yeah.
And they are where you've been. How do you begin to wrap your mind around all of this and focus on healing and health in the middle of all of this stuff?
It's really hard. And, I had a breastie call me over the holidays. And I don't know how, I was trying to be on vacation. I answered the phone, 30 years old, 5 kids, homeless. She had gotten, and just diagnosed, she thought she was metastatic, but she didn't even understand the breast cancer that she had, HER2. It turned out, when I was their stuff, that she was really stage 3. Stage 3B, HER2, so serious at 32. And she's like, the first thing she said to me was, I'm hungry. And I couldn't even get to the breast cancer conversation until I could help her through the fact that she had, I guess, two of her kids by one dad, 3 by the other, and they had taken her kids from her. She didn't know where her kids were. She was worried about, how am I going to get my kids Christmas presents? And she was staying in a hotel that a local church had paid for, but she had 2 more days in the hotel. I said, okay, hold on. When did you last eat? Oh, maybe 2 days ago. I'm like, oh my God. So I literally said, where can you get food right now? And I called the diner. I go, what's the diner? Where's the food? I got her food. But I felt like I was putting a Band-Aid on a flood just to even get her to do $100 worth of food at a diner, but she had so much stuff to undo or fix before she could even think about chemo. And she was showing me her scans and, she was, texting me all the pictures. And I'm like, this is serious. This is some serious cancer. You need to start chemo tomorrow, girlfriend. But she was really so caught up in everything that you just talked about, this is her life, that she couldn't even get to the cancer. And I don't even want to think about how often that happens. I don't even want to put a number on that. But clearly, so many of us are blessed to have insurance or blessed to have good care, but we are not the norm. And, so when I see patients who have all the stuff and can pay for their health care or be covered, they're petrified of cancer. But when you're worried about where your kids are and where you're going to sleep tonight and when are you going to eat next and you haven't eaten for 2 days, oh my God, you can't even get to the fact that, you're going to be throwing up in 2 days from chemo. So it's really, really hard. And I don't even know where to start digging, right?
I remember
one of the best things that happened as people started to really rethink cancer care, and it's not perfect, is that most cancer centers realize that you cannot provide cancer care if you cannot provide social work care and somebody looking at finances and somebody looking at housing. You can't separate those. So a lot of individual centers started to develop the support networks that were not about who's going to just write out the orders. It was about how do we support these individuals through the journey. So you embed those mental health workers to help with the anxiety. You embed individuals that can teach relaxation techniques. You embed social workers that can help you to figure out how you're going to navigate taking care of your children and keeping custody of your children. I know individuals who have more than anything worried about losing custody of their kids because of being sick, and especially if they had had any kind of violent relationship with the spouse. So these kinds of issues, doctors have never been equipped to help with that. But what used to happen is that they would write out, okay, this is the chemotherapy you should get, this is the treatment that you need, and then you got to find somebody else to help with all that other stuff. Now at least we understand you can't treat the cancer if you are not really wrapping your arms around that person's lived experience. It's not perfect, but it is much better than the time when I trained, when you could ask those questions, like, who's going to make sure this person has food? Or who's going to make sure the person's refrigerator doesn't work? You know, you'd be the medical student saying, but wait a minute, well, how are we?
Remember those days. I remember those days.
Chemo when their kid, they don't have anybody to care for their autistic child. Now, at least cancer centers, I think, have led the way in recognizing that treating a cancer is treating a family, is treating an individual with all kinds of other things that come into the mix. We would do well to expand that to all areas of medicine, but I think cancer care really did have to lead the way.
And it makes the patient feel cared for. What people fail to realize is that oftentimes, for some patients, this is the only place they're being cared for. They may not have a supportive family. They may be in an abusive or toxic relationship. So when you come at them with love, even when they're not responding maybe to a therapy, or they may not have even started it, they're going to respond to you loving on them and trying to be kind to them and making them feel valued and safe and protected. So, you know, that's one benefit that I don't think people really understand, or they don't have it prioritized as high. You can give a referral, but oftentimes a hug is better than a referral.
Yeah,
And
it's
it's
funny you say that.
Hard to do during COVID though. But see, I will agree with you and say that I have seen this recently at a patient, a Black woman, a lot of other health issues, rheumatoid arthritis, lots of things going on, psychosocial stuff, maybe some issues at home, deeply religious, completely in denial about her diagnosis. And we really had to love her through understanding what she needed, understanding why it was important, partnering with her from a spiritual perspective and not pushing her spirituality to the side, but saying, maybe God brought you to this place, to this time, to this person to get what you needed to save your life. Maybe there's a lesson and there's a testimony in this test for you, and incorporating all those things. And I saw her getting her report and she said, Dr. Gary, I'm going to beat this. She said, I'm going to beat this. I'm excited about it. I changed my diet. I did this. I did that. Kicked so-and-so to the curb. She made 5 changes before she even started her chemotherapy. And she was smiling and she was joyful going into this experience, which is a testimony in and of itself, you know, not even what's going to happen on the other side, but just all of that. You're so right in that there is still hope and there is still possibility through just compassion, through empathy. You know, and Dr. Reed, to your point, I got to say, you know, the model has been set regarding how we need to really comprehensively care about cancer patients. And I see it in my program. We got a financial navigator, we got a social worker, we got, you know, resources. I'm outside of Philadelphia, but down in Philly, they got one social worker in this health system. They've got maybe somebody who does billing for like everything else and a little bit of cancer. Maybe they have a foundation, and I think pressure has to be brought to bear. You know, it's like Toni Morrison said, racism will continue to be an issue until it hits the pockets and affects the majority, right? Once it affects your pockets, then racism will end. And I think that pressure has to be brought to bear because, you know, COVID is showing us that, you know, these inequities are costing everybody more than it does to just turn a blind eye anymore.
Yeah.
I was saying before we got started that I just yesterday listened to Ayanna Presley did a webinar with the the Roxbury Children's Services yesterday afternoon. And one of the things that she said that really stuck with me, she said, you know, they have legislated racism and inequity forever. that it was legislated, built into the fabric of the rules and regulations of this country. If they can legislate injustice, then we can legislate justice and equity. And that is, and so it is really important, not just that we empower individuals to ask for what they need, which is a huge part, that whole part about sort of patient advocacy. We were talking, Z and I were talking a little bit about that. It's so critical, but there's also this part about what do we legislate to make sure that individuals get what they need. And I think, you know, we cannot rely on people to do the right thing.
No.
Right. Sometimes there has to be some teeth behind doing the right thing. So that means if you're not providing comprehensive care, then you don't get the reimbursements that you would get compared to a place that does provide comprehensive care. Right. These are critical pieces. Right. I think primary care doctors should get paid more than anybody else, because they truly are the ones that, what's that?
I feel like it's going to trickle down. Now, how do we not punish community centers that don't have the resources, though? Because I practice in a community setting. How do we not punish community programs that don't have the resources because they cannot provide all of these services that a larger tertiary academic center does, when, you know, probably 70% of cancer care happens in community hospitals, especially for Black and brown women.
That's exactly right. So that is my point is not to punish those centers. It's actually those places that provide a huge amount of care should get a bigger part of the pie. Exactly. That's what, so legislating equity, right, would mean if such a large percentage of individuals are getting their care in those community health centers, then resources should go toward them and away from the tertiary. I practice in a tertiary coordinated care hospital. I'm at Mass General. And the reality is our health centers, here in Massachusetts, many of our patients get their care primarily in the health centers. If they're not getting it they're coming to the hospitals when they have to, but their relationships, their care, the place where their children are cared for, are in the community health centers. So they should be getting COVID vaccine through the community health centers. They should be getting their comprehensive care as much as possible in those health centers, and the resources should then be diverted into those health centers where the people are. So you can legislate that.
But also, as Andrea and I were talking, I believe in legislative advocacy, because that's the policy, and that's where our voices. We should really try to make sure that we have voices present and that we amplify that, because by the time it gets to us, it's already enacted. Now we reacting, and I'm like, no, let's get in there at the
table.
At the table. So, you know, I tell people, find out who your health care authority is if you don't know. I mean, you don't even have to leave your house now, honey. You can do a Zoom meeting and listen. You know, who and what are your boards and commissions that would allow you to take a seat so that you can begin to be an influencer in your own health. Our role is beyond patient. We can actually go into legislative advocacy. We can become commissioners or members and all these different things, so that actually we are empowering everybody. Because if my health gets better, everybody's health gets better. This is not segregated. This is not only going to happen for the Black people. Everybody's going to benefit from this, you know. And so
but it's really hard to do all that when you're sick, though. You know what I mean? Like at some point when you have breast cancer, like, you know, you almost like at some point you just have to like figure out how you're going to get through the day.
Right.
And, you know, I talk about the side effects of chemo, and you know, they give you this list of things. I say this all the time. Don't call it a side effect. Call it, I can't go to work.
Right.
Call it, I can't feed my kids. Call it, I can't get out of my bed today. Like, it's like how it affects my life. And so when you're dealing with all of that, and then you have to worry about, oh my God, can I pay the bill or whatever? It's just.
But I'm talking about our advocates.
Right. Being
I'm
vocal
an
about what we need.
Being an advocate.
No. And part of my advocacy is legislative on behalf of my patient, because I want to make sure that my patient's voice is heard wherever there's an access point, if I can help it. So that if it can't get done in the physician's office, maybe it can get done in a politician's office. I don't know. But I mean, our advocacy efforts on behalf of our patients,
right?
Be a little bit more focused, if at all possible, on legislative advocacy.
I love that. Z, let me ask you where patients and survivors can go, because I think an important part of survivorship is making sense of this journey and then transforming and translating some of what's happened to you into advocacy. I find that so many patients are able to do that successfully and begin to kind of use what's happened to them as a springboard for creating change, right? Where does that transformation happen? And Ricky, my question for you is on the part of the personal responsibility of the patient, because I always have to play the doctor on the other side, because that's why I'm here, is being the physician, right? When the patient comes to see me and they sit like this while I go through, and I spend an hour and a half and I go over every single thing with them and talk about all
she
the
didn't say anything to me. She didn't explain anything.
And they sit there like this and they go, I had to think about it. And they walk out. And I'm like, you got stage 3 cancer. You got to get busy, sister. Let's go. Where is the individual responsibility to the patient? How do we counsel and coach and support our sisters to get there beyond disbelief when they get a good doctor, when they get somebody in a health system that's supportive for them?
It's all about love. It's all about love. They have to feel the love. And Mo, it's like the patient I was texting you about yesterday. You know, it's all about love. And I think that you get so hung up on all the stuff that you have to deal with. They want to feel love. They want to feel hope. They want to know there's a way out. They want to know that they are going to get through it. But those are the calls I get, because after they leave your office, they call me and say, all right, well, the doctor said, rent, do the chemo, do the whatever. What should I do? I'm like, well, I'm not a doctor, and I'm going to call Dr. Mo anyway and ask her what to do. But they want to hear that I did that. I had that chemo and I'm still here. That I did that radiation and I'm still here. That I did that surgery and I can talk about it, and I can send them to 5 other breasties that had the same experience. Wow. So they want the validation, because the validation of what you tell them gives them hope and love.
So I hear you talk about advocacy through survivorship and partnership with survivors with current patients, right? I don't think there's a name for that. What's the name for that program? Doc, do you guys have anything like that at your system? Because we're working on trying to develop like a buddy system, but I wish it was more ubiquitous.
I don't think, I don't deal a lot with breast cancer. I have two very good friends going through it now. I don't deal so much on that end, but I deal a lot on the liver transplant and liver cancer side. And there are unfortunately some parallels. And one of those is that, everyone's very afraid, of course, anytime you hear the word cancer. Right. But also I think because there's so many different regimens and so many different things that can be done, we overwhelm patients by giving them lots of information. So the one thing that I say, no matter what, is when you have a diagnosis, we're giving you information. This is the beginning of a conversation. This is not a conversation where you're going to make a decision. We're going to start talking about it. I tell all the patients, bring someone with you that can hear the things that you will not hear. Yes. And it doesn't matter. That's where the partnership comes in. It doesn't matter if it's a family member, a friend, but somebody else in the room can hear the things that your brain shuts off. Our brains shut off when we're overwhelmed. And so having somebody else in the room, and then I'll do a follow-up call to make sure that what questions do you have now that you've been able to sort of mull it over for a little while. But individuals that come without an advocate versus those that come with an advocate, I think their care is very, very different.
It is.
And being able, I think for breast cancer, such a powerful thing to be able to say, there is a group where if you have questions, you can bring them to this group of individuals that are survivors. One of my dear friends that has it, the first thing I did when I found out that she had breast cancer was I contacted Ricky, because I think that ability to have someone who's made it to the other side, but also has such a positive way of thinking about how you attack breast cancer, the way you educate yourself is so powerful. So that network, I hope that this model that you're talking about, I hope that expands and is available in every healthcare, system that provides breast cancer care, especially that there is some way that they're connected with a navigator. If they don't have one of their own, a navigator that will really be there and listen for them, listen with them, and then help them to ask the questions that sometimes they can't give voice to.
Yeah, breasty love. There's nothing like breasty love.
Talk to me about navigation and the training that you received and the training that you wish you received, and how you then train other navigators, because I know you do. You might not do it formally, but I know you do. And if you do it formally, we'd like to know also, because there's lots of folks who would like to help begin to do this work. And so I want you to talk about your experience and your training in navigation, but then what do people really need to know in order to do this work?
Okay, I'm a non-clinical navigator, meaning that the focus is more along psychosocial, social determinants of health. But there is care coordination involved, meaning making sure that the appointments, they're being scheduled, that they're being adhered to, trying to find out, okay, if they didn't get the imaging, is it in the process? Where is it in the continuum? But actually, navigation has evolved to such an extent. When I initially began, there weren't all these various types of navigators. Now you have a navigator for everything. And as a result, I was just telling Andrea that to a certain extent, I feel like navigation has kind of lost its true intent. I was fortunate enough to actually attend a training by Dr. Harold P. Freeman, who was the father of navigation. His intent initially was to create it as a peer-to-peer service to help women of color and underserved communities get help. Well, now navigation to a certain extent has become so professionalized, you don't even see Black women in navigation roles, especially when it comes to the nurse navigators. So something is already kind of being lost. A lot of programs don't invest in navigation. So there is no peer-to-peer component, okay? And then because of the way inequality and equities have evolved, for example, I might spend half my day just dealing with insurance because insurance itself presents one of the biggest barriers and poses some of the largest inequity in healthcare than, I can even deal with half the time, because there's so many different various types of insurance, especially in California, because you have it for all type of groups, and trying to figure it out, when a patient is confronted with the share of costs, how do you deal with it? So you need to know something about your Medi-Cal system. You need to know something about your insurance systems, just so that you'll be in a position where you can identify what's happening with insurance if you don't have an insurance navigator. You need to know something about social services, because if you have a patient that's in the social service safety net programs, what do they qualify for? What can they apply for? When is their recertification? Should they meet with a social worker with that particular social service agency? And they may not have the bandwidth. Is it housing? It's so siloed. And what I've learned is that we design systems that don't have the patient's perspective or sometimes even their priorities in mind. Because when you're a cancer patient and you have your PCP, you have an oncologist, now you might have to go to a radiation, you might have to do all this. You're not trying to have 5 other agencies that you have to deal with on top of that and keep track of appointments and this and this and this and that. So one of my goals is trying to figure out how to create a system of navigation that's almost one stop in terms of dealing with social service and insurance type of inequities. It's too much for the patient. It's too much as it exists to have all these different silos, and you may have no help, or you only may have one advocate and they don't understand it either. So now your advocate or your family member, they have to try to understand your diagnosis. They have to try to understand the type of insurance you have. They have to try to understand what resources may be available if you're elderly. Now they have to try to understand where to get food. It's just way too much. And I think that's what I'm learning as a navigator, is that it's not a stayed position. It evolves constantly, just like the patient's life, just like the disease. And you have to try to create a system that is evolutionary. It can't stay the same. It has to always be ready to grow, to learn, to change. Because if not, what's going to happen is you limit your usefulness to the patient. Because if you only know about 2 types of insurances and it's 12 out there, okay, so they're missing out on 10. Perhaps. And there has to really be a intentionality into how we develop these systems and how we invest in them. Patient navigation is still not really invested in to the extent that it should be. And as a result, we are not positioned to realize the system's full potential and its full efficacy and its meaningful impact in the patient's life. So I find like I almost have to advocate for the patient and patient navigation in order to really help my patient to the best of my ability. So that's really what I'm learning. And I would tell people, in order to be a navigator, you got to have a heart. You got to have love in your heart. I'm telling you that right now. I don't care about your academics. I don't care about your experience. I don't care about how many empathy classes and motivational listening. I don't care about none of that. At the end of the day, you have to come with love. You have to come understanding that everybody is valuable. I don't care about your race. I don't care none about that, because these are not patients. These are mothers. These are sisters. These are daughters. That's what they are.
Can I tell a story about that? Can I tell a story about that? I want to interrupt you. So last year I spoke in a panel with NAMA and SABCS, Mo, and I don't remember the doctor's name because I probably bad things I just put out of my head. I call it chemo brain, right? Mm-hmm. So and she was a white doctor, and she was talking about how well I have a nurse navigator in my office, and I give people gas cards, and we provide Uber transportation if people need it. And we have all these services in my practice. And I said, well, how are they doing? And she said, well, I don't know. And I said, well, why don't you know? Well, wow. I don't really handle it, but I know I spend all this money. I give all this stuff, and I have it all in my office. I said, well, and she said, well, nobody asked me for it. So, the patient didn't ask me for it.
Wow.
So, well, how would the patient know? I said, okay, I'm the little poor Black breast cancer patient. Doctor, can you please give me a gas card? Like, not going to happen.
We didn't even know to ask
no clue that we're not going to ask for that stuff. We're not going to ask for those services. And, and she was so disconnected from the reality of her practice.
Yeah.
And, she was in front of a room full of Black breast cancer survivors. So, how that went. Right? But yeah, and in her mind, she felt like she was doing the right thing because she had all the stuff, but nobody was using her stuff. How would they know? And she was just waiting for somebody to ask her for it. So it's a crazy system.
Well, and it speaks to a really good point though, Ricky, of monitoring and tracking what you do as well. What's successful, what isn't, what works, what doesn't, where do you need to give more resources? Because if you don't know, if you just, have gas cards available and it's sort of nebulous and you let somebody else handle it, you don't really know the impact of what you're doing, and you're not making your cancer program perhaps as effective as it could be, and so all the things that we do in my program, I'm medical director of a cancer program, we monitor, we see, and we offer it to everybody. This is the other thing we don't assume. Right. Because cancer is a tremendous equalizer. And I don't care how much money you made, you did not budget for breast cancer. I don't care how many vacations you missed in 2020.
True.
This wasn't in the budget.
Yeah.
And if there's an opportunity for you to get some resources and for you to have some support services that are available to you, then you should take advantage of those as well. But what we measure and what we monitor, we're able then to really grow and to see the fruits of those programs. And so it's kind of sad, kind of laughable, but kind of really real. That, she doesn't have a clue. She's basically doing her clinical stuff and expecting somebody else to do the rest of it. And we can't operate in those silos when it comes to patients. It brings to mind that quote Maya Angelou said, nobody cares how much you know. People don't care how much you know.
Think about how you make them feel.
How much you care. Until they know how much you care.
Right.
Like the care has to come first in cancer.
And it also says she doesn't know her patients. That she doesn't know.
Exactly. No. And the thing is, one thing I can honestly say, and I'm so blessed because I don't have those issues with my doctors that I work with. Love is the equalizer with my multidisciplinary team. We care and we love our patients. So there's no hierarchy, there's no program talk. It's all about we're identifying.
Everybody's all in. Yeah.
So did Miss So-and-so what did we? It's just all about communicating and figuring and doing, and that has been so effective. And that's what allows me to trust the system, Because I'm not going to go out and tout something I don't trust. I'm not going to be the Flavor Flav for no program out here talking about something that is not true, especially when it comes to something like cancer. So because I know the character of the doctors I work with, I can go out and tell my patients with certainty, no, we're going to do our best. And it's not the company line or any, and that's why, you know, the more we start, or for myself, we start to recognize our systems as systems comprised of people first, then I think that kind of like allows us to have communications in a different vein. It's not just these elusive programs and these policies. Now I'm talking to Dr. So-and-so, and I can identify this is what they do. This is how we can maybe work something out. So it's all about loving people at the end of the day.
You're in a great system. I tell my patients, you know, again, I deal with a lot of liver patients, and my mantra to my patients has always been, one, I will know you. I will know you. I'll know your story. I will know I've had trainees who say, how do you know your patients so well? Why do you remember them all? I said, because I ask them about who they are, not as a patient in my office, but who they are when they're not with me. I know who their grandchildren are. I know their worries about those grandchildren. And it takes a little extra time, but then they stick. They are in my brain. They're not going anywhere. But the thing that I tell them, again, because I deal with cirrhosis and liver cancer, and sometimes you can't make that all better. But I tell every patient, when I cannot cure, I can always care. And that no matter what else I can offer to you, I will always offer you an ethos of care. And that, I think, is the driver for me in medicine in general. And one of the things as an educator that I think we have to do, because, you know, now I'm a dean at Harvard Medical School, one of the things that we have to talk about is the fact that we can teach people all about these different differential diagnoses and treatment protocols. If we don't teach them to see patients as whole individuals, then we have missed the mark. Right. And that it may take a little longer, but we need to build in discussions about equity and access into everything we teach, not a separate class, not something that gets added on. Okay, today is the equity lecture, or today is we're thinking about social determinants of health. It needs to be built into how we evaluate their competencies as their medical students. How well do they communicate to us as their attending physicians, their assessments of the impact of social determinants of health on these individual patients? Once it becomes part of the assessment, then they'll care about it. But when it's a one-off, it's not going to have the same impact. So if I could change anything about medical education, that's it. You build it into the infrastructure. Everything that they're getting tested on includes these very important, because you know the impact of social determinants of health, or just lived experience. You know the impact that has on health, right? But in fact, it's rarely taught.
Yep, you know
so
what?
We've got to change the system.
You're absolutely right. I'm on faculty at Texas Christian University, where they have a model of empathetic scholars, teaching empathetic scholars, you know, and it is such a powerful and empowering model for the students, but you got to take it a step further because it doesn't trickle up. Right. And so we are sending these students, they're on fire, they're well equipped, they understand, they're ready to see these patients as themselves. And then they get to their rotations and they are fraught with physicians who say that doesn't matter, get back to the work. And why are you focused on that? And all these things, right? Like we got to change the culture from the top down as well, because, you know, these kids hit the brick wall. And they're like, wait, it was just a class. Oh, it was rhetoric. Oh, it was in practice. It doesn't work, you know. And so we got to work at it from both ends, Doc. I mean, we got it bad on both sides, and we see it, you know, like this. It has to change in clinical practice, and we have to challenge our colleagues, you know, on how we see and how we manage these patients. We got to ask those questions. Why would you say that? You know, we can't just call them out now. It's calling in, right? We got to say,
well, and then you got us the patients.
What makes you say that about Ms. Jenkins?
Tell me more about that.
Tell me more. Right.
Hey, you guys, we're running out of time, but I wanted to talk about one more thing. You know, this is near and dear to my heart, Mo. So all the Henrietta Lacks, all the whatever, all the Tuskegee stuff, laws were put in place, right? So that all of that stuff is illegal now. Because I want people to, you know, I'm on this whole bent about trying to get more Black women to participate in clinical trial research.
Yes.
And so I want people to know that they can confidently believe that if they are involved in research, they're not going to have to worry about being screwed over. So
Mhm.
Right.
can we just talk for like a second about, like research is different now. The simplest thing can't happen anymore.
Right.
And we all learned a lot from that. And it was a horrible time, but like, where does the world lie now with regard to that? Like, how do we make people feel better about participating in research?
I have to say, and I'll start, and I know we'll all have something to say about this. The first thing is that things are much better in that there are protections and safeguards, lots of safeguards. There's data monitoring safety boards. There are individual rules that are set up by the National Institutes of Health and by the government to prevent abusive patients. There's like even who can be included in patients. Vulnerable populations have to be treated with particular care. But what is not legislated is making sure that the studies represent the patients for whom that have the overwhelming burden of the disease.
Hello,
So this is
that's why Black
okay.
women
So
are
this
dying
is
of breast cancer.
right,
Hello.
exactly. So if you're going to do breast cancer studies, you must include breasties with triple negative cancer. You can't say you're going to do that and not have overrepresentation of women of color. You cannot develop COVID-19 vaccines and say that they have a certain efficacy and not include older individuals or Black individuals or brown individuals or Native Americans who are dying who have the highest rate of getting severe COVID of any population. So that there's a requirement, there's an understanding that this should happen, but in fact, the requirement that studies don't get to be published until they have these numbers, that's not in there. So I think the key though is that people need to know that they'll be safe within a study and that their participation increases the representation of individuals that need to be in those studies. But I say to researchers, it is not the responsibility of the populations that you want to come to your Ivy Tower, to take time off of their work to be a part of your study. The key is you get some other Black and brown people or community health workers to be partners in the study.
Mhm.
Bring the study to where the patients are. Don't make the patients come to where you are. Let them know. If you want to include them, then for you to ignore the Black church and community health centers is to your detriment. So don't say you can't find Black and brown patients. Go where the patients are and let them see that their caregivers, the people they trust, that those people are partnering with you. And then listen to them as to what their needs are. Don't assume you know what their needs are. Listen to them and incorporate them in your studies.
Amen.
Wow. Yeah, yes. We the doors of the church are open. We about to have an offering and a benediction up in here. But you're absolutely right. I would say that when we are at the table, we are less likely to be on the menu. Now more than ever, there are Black researchers and Black scientists and Black physicians who are not even beginning, but continuing the work. As Dr. Reed's been doing this for many, many, many years. Like, you don't know, I'm a follower, I'm a fan.
We're trying. We're trying.
But this work, you got some laborers and some helpers in this work. And I need for people to know that this isn't new to us and that we are at the table. So we won't be on the menu. And what that means, I think, to our community is that, it's time to turn the page in that we as a community, we as individuals can begin to develop strategies for how we want to advance our own health equity initiatives, how we want to care for our communities, how we want things to look a little bit different, especially in cancer care. Ricky, I know you've done an amazing job of talking to our breasties and our advocates about and the importance of clinical trials and making resources at their fingertips to participate in these clinical trials, even as much as reimbursing and subsidizing and giving extra benefits and money to participate in these trials. And so I think that for the person who's watching, who's thinking about it and saying, you know what, that's far from me, it's not far from you. Whether you're a survivor, there are trials that aren't drug trials that you can get involved in.
I just joined this trial, I told you, right?
Right.
Yeah.
Whether it's COVID, you can get a vaccine. You can talk to a doc about it. Any of us, you can message us and we can talk to you about it and go over the data with you and talk about your concerns and your fears. But it has to do with taking that next step and reaching out and that accountability. I think that's what I want to say about it, is that this is the time and we are the people, but that it can happen again. And we need to be careful. We are the gatekeepers and the guardians. When you look at what happened with hydroxychloroquine, right? They started giving it in nursing homes and prisons and places where it wasn't approved yet.
Oh my
And so we
God.
got to be vigilant. We have to stay vigilant, and it's okay to ask questions. It is so
It's
okay.
imperative
So
to ask
okay.
questions.
It's
It's
so okay to ask
imperative.
And
questions.
if I can, I just want to acknowledge all the CBOs, the Black CBOs and collectives that are really holding us down. We have a fabulous Umoja Health, United in Health Oakland, run by Dr. Kim Rhodes. I would be remiss if I did not mention her. She is incredible. We started out with COVID pop-ups. Now we're starting to go into cancer. We're starting with FID, and hopefully we'll get to breast because of the expansion of the work. And the thing is, when we love community and we seek to empower and heal community, the expansion always comes. So don't worry about where you at, envision where you want to go, and come together around that, and we still make a difference.
Mm.
So great.
Wow.
And,
You
and
guys
know
are
that
awesome.
Eastern and Western medicine are not necessarily always in contradiction
Right.
and contradistinction, right? We can walk and chew gum at the same time. You know,
That's right.
we can use our herbs where we need to. We can use chemo and surgery and everything else. Like we ain't new to this. We true to this. You know, we can heal ourselves, but we can use wisdom and guidance in every physician and every researcher and medication that is available, in addition to our herbal and holistic options as well. It doesn't have to be either or.
Absolutely. Absolutely.
Wow.
Wonderful conversation.
You guys rock.
You rock.
Yeah, totally right.
Really do.
Thank you
We
so
really
much
do.
for having us. I'm
Thank
so
you
happy to
so
meet
much.
Dr. Mo and Z.
I'm so happy to have met you guys. It was just awesome. It's such a blessing and a privilege to be here with you ladies. You're all so awesome. So thank you.
This is only the beginning of the month. I'm excited. I'm on fire. This is the
know.
start of Black History Month. We about to have some serious
Excellent.
conversations and make some change here, make some powerful moves. So we want to hear from everybody. We want your comments. We want you to share. We want your questions. We want your debate. We want all of it this month so that we can continue to move this conversation forward, because you know this is what this is about. It's for our cancer patients, yes, but it's also for our community, it's for our advocates, it's for caregivers and navigators, and everybody knows somebody who's had a cancer diagnosis. And so this is important information, and we hope you share it with each and every person that you know. And we want to hear back from you. We want you to be a guest. We want your questions and participation in it.
Yeah. So next week, we're going to do Mega Thriver Mega Moms. So we have 3 breasties who are all young, with young babies dealing with metastatic breast cancer. And the next show after that, we're going to do the wife has breast cancer and the husband has prostate cancer in the same house. So if you guys know anybody, any couples dealing with that, you know, text me, email me, tweet me, whatever, and we'll bring them on the show, because I think that's a really important conversation, because who's the caregiver?
Yeah.
Who's the caregivers? That one's it's all about love, all about love. So thank you guys so much.
Thank you for
Want
having
to
us.
say how you can reach
Thank
you?
you.
How can we reach you guys?
Please.
I can be reached. My email is andrea_reed@hms.harvard.edu, and happy to hear from anyone that has any questions around, you know, our history, medical apartheid, around social determinants of health or advocacy. I'm be delighted to talk to them.
And liver disease.
And
Anything liver related, I'm happy to talk to you.
And mine is my name, Jeanette, ZHONNET @gmail.com. And I will answer all your questions as well.
I'm Dr. Monique Gary on all social media. I certainly want to hear from folks who are interested in continuing this conversation. But if you want to figure out how to get involved, you know, if you're a breastie or a survivor, we want to hear from you also. And we want to connect you with resources that are local to you. If you need a doctor, if you need a second opinion, we have a network of Black physicians that we can connect you with. And so we hope that you will connect with us at Touch BBCA. But I'm Dr. Monique Gary on all social media outlets.
Great. And I'm Ricky Deb. I'm at Touch BBCA. You know how to reach me, text me, I'll answer you. And thank you so much. And we'll see you next week. The doctor is in.
The doctor is in. We hope it's been relatable, reliable, and real every single Wednesday.
Yeah. Breasty love.
Shout out to Harriet's Bookstore.
Oh, yeah, look.
Philly,
yeah.
right? I'm highlighting every week as a Black-owned business. This is a sister who has a bookstore that is designed to highlight and celebrate Black authors, Black artists, Black advocates, and activists. And she has a line of T-shirts that Target ripped off. So if you are looking for these shirts, because I'm from Philly, so we Johns. Everybody's a John. If you're a well-read John, if you're strategic John, if you are interested in supporting the merch, Harriet's Bookstore is the place to go in Philly.
I love
That's
Harriet. I love
fantastic.
Harriet. Yeah.
Peace
All right,
and-
you guys. Thank you.
Thanks for having me. Bye-bye.
Thank you.
Bye.
Bye.
Bye-bye.
Bye.
Bye-bye.
Bye.